I was requested to give an introduction and talk about the simple question, are we on track with quality measurement in general practice? And I was, okay, so this is the question I will try to answer. I will do this in 3 parts. I will present you and report you on some developments in the Netherlands. I'm still work in the Netherlands for more than 20 years in the general practice field as a researcher. I will also offer some analysis on this. Then I will briefly present you a particular practice that illustrates some of the points I will raise, and then I will end with a discussion and some ideas, some hypotheses, and this will be all in about 20 minutes. Conflicts of interest that I would like to mention is that I receive funding for some of my work from both the Dutch College and the Dutch Association of General Practitioners in the Netherlands. So first, a short history of general practice in the Netherlands, and particularly with a focus on quality. As a background, the Netherlands, as you probably know, is a densely populated area. For comparison, I give some information about the area in which I'm now situated, which is Baden-Württemberg, an area in south of Germany, but I will not expand on that now. So the Netherlands is a densely populated area, particularly in the west of the country, I have to say. Healthcare is funded by insurers, health insurers. There are 4 large insurers covering 90% of the market. The position of general practice is seen as very strong. The GP is the usual point of first access. If you want to see a hospital doctor, you have to go to a GP first. And the package, the range of activities is quite comprehensive. So general practice is strong, I would say, like in Denmark. And medical students actually have a lot of interest. There's sufficient interest among medical students at the moment to become a GP. A short history. Perhaps it starts more or less in 1970. Of course, the history, general practice started long before 1970. There have been home doctors, general practitioners for more than 100 years. And the college is also 60 years old. But let's say in 1970, the vocational training program started first with 1 year, then 2 years, 3 years, and a number of other things, and the registration system started. This was a period of emancipation. Then there was a period of growth. So the quality activities, the quality measurement and improvement was expanded. GPs got more active in prevention, also more active in lifestyle change, in patient education, and all sorts of additional work. Then we moved more recently in an area of transparency, not just in general practice, but external stakeholders, the minister, inspection, and also patient organizations and insurers asked for data to show that general practice was actually performing well. This was quite close to bureaucratic control. Bureaucracy, and I mean this in a very neutral way, because bureaucracy is not necessarily a bad thing. It's an alternative for corruption and nepotism, but it also had some side effects. And this led more recently to a high degree of dissatisfaction among GPs in the Netherlands, and I will talk about that in a minute. I think these different phases are important to understand quality activities and particularly quality measurement as well. In the first phase, the emancipation phase of general practice, measurement mainly had the purpose of making general practice visible. For instance, in registration networks, GPs documenting what they do the whole day and use this for scientific research, but also to make visible what is general practice, what is happening there. In the second phase, measurement was mainly for improvement. So it was very formative. You did measurement in the context of quality improvement projects to learn from your performance and see where there's room for improvement. In the in the next phase, the emphasis was more on accountability, showing to others how well the performances or the quality or the outcomes are. And that comes immediately close to measurement for control. Other people, insurers, inspection, and others also had the opportunity to control what was happening there. And as I said, this led to a current phase, with, at least among GPs, dissatisfaction among GPs. As an example, I will briefly talk about practice accreditation in the Netherlands. This is a system or a program developed by the Dutch College of GPs, which is, I would say, voluntary in the end. On the other hand, GPs are obliged to take part in some sort of registration activity, and this practice accreditation is one of them. The reality is that 65% of Dutch GPs have done practice accreditation, 65%. This is not the same as the number of practices, by the way. It's 65% of doctors. It started this program with a strong focus on quality improvement. The idea was that measurement by itself is not very helpful. It only helps you if you can learn from it and improve the practice performance and your work for patients. The core activity, also in terms of workload, was a comprehensive measurement activity. So in 3 areas, roughly: chronic disease care, so lots of indicators of chronic disease management, mainly process indicators like have you seen diabetes patients 4 times a year, and also proxies of outcomes, blood pressure measure, controlled hypertension levels, etc. There were also some measures in the area of organization of practice on the basis of questionnaires mainly, and also a patient survey was included. We did in Nijmegen some studies in which we try to evaluate this system. The first study is presented here. We focused on diabetes and COPD. We saw in the group of practices that participated improvements on the indicators for these 2 diseases, but these could not be related to the participation in practice accreditation. It was a slightly difficult design. It was also an observational study. But anyway, the take-home conclusion is it was improvement, but not clearly related to practice accreditation. We did another study. This was actually a randomized study. But as you can imagine, it's very difficult to randomize practices into practice accreditation versus no practice accreditation. So we randomized them into focusing your improvement work on cardiovascular disease or focus on a different area. And again, we found no impact on the primary outcome, at least within the practices who participate on improving cardiovascular care, although there were some effects on secondary outcomes. Interestingly was the qualitative study, the interview study that was attached to this. Quite a few GPs said this practice accreditation is fine, but a lot of work, they also said. But they also said it has little to do with what we do in our work. It has no meaning, no relevance for the quality of my work as a doctor. The study and these studies were discussed, for instance, in the Journal of Dutch General Practitioners, and the argument was made that this should not be the end of practice accreditation because it has several purposes. One key argument was that it was not only, or perhaps not mainly for improving the practice, but mainly for accountability. I think what you can observe is that this practice accreditation started mainly as a quality improvement activity and has now developed into an accountability exercise. So something you do to show to your patients, to the public, to the payers, how the practice performs. As I said, there was a not a strike, but a movement among Dutch GPs last year. A small group of GPs took the initiative, really a grassroots movement, you could say, and they had an online, there was opportunity to sign to agree with it on a website, and within a few weeks, the large majority of just Dutch GPs did so. They signed a key document. And the key themes in their statement was that GPs want to focus on the core values of general practice again. I will talk about that in a minute, what these core values are. They also want more power in negotiations with insurers, because in the Netherlands, the GPs are not, it's not allowed to organize themselves. So there are 4 health insurers and 11,000 GPs. That's unequal negotiation situation. And it's, for instance, in Germany, there are organizations that negotiate on behalf of the doctors, and that's not allowed by law in the Netherlands. And last, but very important, was that the administration, the burden of administration should be reduced, also in quality programs. It's not just about quality, because doctors have to fill in all sorts of forms. If a patient needs a certain device at home, there has a form, and if you want to refer to a nursing home, there are long forms, etc., etc. But also in quality programs, they want to reduce the burden of work. As a small sidestep, I wondered myself, is this a natural order? You may wonder yourself, is this the same in Denmark? Not necessarily. I work now in Germany, in a particular region, Baden-Württemberg, and I think that in this region, these 3 elements of making general practice visible, measurement for accountability, and measurement for improvement are much more mixed. They go all at the same time, it seems. This is illustrated by a program called GP-Centered Care, which is a voluntary program for both the patient and the doctor, which gives doctors a central role in chronic disease management, diabetes, COPD, coronary heart disease, mainly. There's an ongoing evaluation. The program exists for about 10 years now, showing that indeed more consultations are with general practitioners and fewer with specialists, and impacts on a range of other indicators. As I said, this measurement had several purposes. It made visible what general practice was actually doing, particularly to decision makers, which are in Germany various, ministry, health insurers, and others. It also was important for accountability, particularly to the health insurer who was paying for this. And it also helped to improve the program. This was a small side step. In the Netherlands, the Dutch College and the Dutch Association embraced the ideas of this movement. Het roer moet om. The direction has to be changed. The steer has to go in a different direction. And they wondered, can the core values of general practice actually be measured? As you know, many aspects of general practice could have a relevance for the quality of care, from availability, accessibility, to perhaps cost and efficiency. So what are the core values of general practice? There have been discussions about it in a structured way. Working groups have worked on it. And then the Dutch College produced a document saying that there are 3 core values. Generalistic, so comprehensive, it's for all patients and for all health problems. It's person-centered, so general practice is not about organs or cells, and even not about diseases, but it should focus on individuals, and it's continuous over time. It struck me that access, easy access, is not listed here. It's actually integrated, included in continuity of care. I would personally recommend to list it separately, but I think in the Netherlands it's more or less taken for granted. The access to general practice is very good, so it's taken for granted. Then the question is, how can this be measured? Can it be measured? So these three core values, from patient records, from clinical registers perhaps, from interviews or questionnaire data with healthcare providers or from patients. I don't know if you have views on this. We did a small project, an inventory project for the Dutch Association of GPs who had this question, and we noticed that there is a range of measures actually already available, mainly questionnaires, mainly for patients, but also some for doctors and nurses. And there are also some measures, but not so many, for extraction of data from medical records. We would say our recommendation in the end was that a mix of approaches is needed if you want to measure these core values. However, a challenge will remain to avoid measurement burden, because a risk is that this is all additional. I don't know how this will continue. There are also GPs, also in our working groups, who said that it is fundamentally impossible to measure the core values of general practice. So they say it's not a viable option. So the debate is still going on, so to say. Now I want to move to a second part of my presentation, which is a practice, which is, I think, in our context, quite innovative. This is the practice building. It's a practice in a rural area. Rural is always relative in the Netherlands. But let's say the closest hospital is 10 kilometers away, and this village has 3,000 inhabitants. And as you can see, the practice building is actually quite old. It's also the house of the doctor. But if you look carefully, you see the solar, so the sun panels, solar panels on the roof. So it's also in other ways quite innovative. This practice did a project which they related also to some other ideas about positive health. The practice owner is Hans-Peter Jung, by the way. He was one of my first PhD students and did this in a project actually with the University of Aarhus 20 years ago. Here you see some figures illustrating the development of this practice. So he started in 1995 with 4 providers. One of them was a medical doctor, so he was the medical doctor. And now there are 11 providers, so it's enormously many more providers, and including 2 doctors, 2 GPs. The number of contacts has increased enormously, total and also with the GP. However, as a consequence, the consultation time has decreased quite a lot, from 15 minutes to 8 minutes. The regular, most common consultation time in the Netherlands is 10 minutes, at least that it's scheduled. And in reality, it's more like 11 or 12 minutes. And also more patients have been referred, although the total number of patients registered in this practice has not grown so much. As I said, they created an innovative project. The arguments were that we have a mixed system like you have in Denmark for payment, in which part of the income or the total production or the reimbursement comes from consultations, numbers of consultations and numbers of procedures. And he argued this should have less impact. And we also want less administration, more flexibility in our time, and we want these 50-minute consultations back. So give us, please, for 1 year or for 2 years, a fixed amount of money, and we will show that this will improve our performance. And this he did. He created some publicity in the local newspapers. This article says, an old-fashioned GP with a modern look. And there was actually another one. No. He also collected data over all these years. You see here data on the number of consultations. And as you see, they increased over the years, but in the last year, there's a decrease, it seems. So this is an intended effect. And also the number of referrals, this is only data from 16 showed first an increase actually, but then it decreased. So also what he promised to do. This is still running. Back to the question of today, how would you measure quality in this practice? It could be an open question to you. It's not a format to discuss it now very interactively. There are several options. You could survey or interview the patients to know whether they are happy with it or how they perceive it. You could interview GPs. You could perhaps even do case studies. Actually, he convinced the director of the health insurer by taking her one day with him. So she went with him to home visits and sat in the consultation room. And then she gave her, or this insurer gave him the money for this project, or the approval for this project. I don't think it costs money. You could also say we don't need measurement of quality, only some basic monitoring of cost and volume. So this could be a point for later discussion, perhaps. How to measure quality. Okay, to come to my conclusion, I have tried to make clear that quality measurement may have different purposes, and these purposes are relevant, are important for how to measure and what to measure. Three purposes are listed here. First of all, a purpose can be to make the added value of general practice visible. And this is where it once started. And one idea could be that it goes back after the historical development in the Netherlands. We are going back to this somewhat, in some way, again, to make the added value or the core value of general practice visible. The second purpose can be to guide and assess efforts to improve practice, so quality improvement projects or programs. And the third purpose can be to satisfy stakeholders. Can be many stakeholders, insurers, inspection, could actually also be organizations of GPs. It's also a stakeholder. There's a wide range of issues that you could measure, and there are also technical issues to consider. For instance, how many measures, how many patients, if you do a patient survey, how to deal with case mix, differences between practices. Some practices have very old patients, others have younger patients, how to deal with that, how to work with benchmarks. These issues are also important, but were not so much the focus of this talk today. But these technical issues also have to be considered. That brings me to my three hypotheses to conclude. As I said, I think if you want to measure the core values of general practice, again, I can perhaps add, I think you need a mix of measures, surveys among patients or interviews, health professionals can be surveyed. Some, but not so many, indicators can be derived from patient records. And perhaps you could even think about very different methods which are not so representative, but have some other advantages like case studies or presentations of individual patients, particularly if the emphasis on showing what general practice has to offer to the world. As I already said, I would say that measurement methods are important and technical issues have to be considered, but even the most advanced methods cannot really solve issues related to impact, positive or negative impact. For instance, issues whether you sample or do your survey with online questionnaire and online sampling, or very advanced ways of adjusting for case mixes, or more advanced ways of benchmarking. These are all relevant items, but will not solve how the quality measurement is used in practice and in policy. And my third hypothesis is that measurement of the core values may help to resist, may help to counteract some negative influences. First of all, it makes visible and also may help to increase the trust, what GPs do. And it also may counterbalance some of the negative effects of bureaucratic measurements, bureaucratic control, and also the negative effects of competition and fee-for-service system, which emphasizes or stimulates many consultations and many procedures. Of course, my claim is not, of course, contextual factors are very relevant to understand this. The position of general practice in the healthcare system, the governance, the way it's coordinated, is there competition, is there coordination, is there a mix of the two? The economic or financial incentives play a role, and also cultural factors, for instance, trust in general practice. So I do not claim that this can all be directly translated into Denmark or a different country. This has to be considered and discussed. The challenges in the Netherlands, we wrote a reflective paper some weeks, and this was published some weeks ago in the Dutch GP journal. I think here, to reduce the administrative burden in general practice is one main challenge, everybody agrees, also in quality measurement. For instance, this practice accreditation exercise is means an enormous workload for practices, not just the doctors, but also for the others in the practice. A refocus on core values. I think all in general practice in the Netherlands have embraced this. It also means actually that some organizations or departments in organizations have to be downsized if they do not contribute to this. Health insurance, for instance, have created large departments for all sorts of quality measurement, quality work, and perhaps this is not so needed anymore. And there are also similar departments or organizations in other areas. And fourth, this was our fourth point and final point, is that in all these changes and developments, it's also important to keep a scientific attitude, because the whole movement has refocused general practice on core values in the Netherlands, but it did not say anything about scientific evaluation or scientific development in this area. And I would say, as a minimum, evaluation, but also scientific reflection on these developments remains crucial if general practice has to remain an academic profession. Thank you for your attention.